Hi, thank you for joining us for DDU Viva Practice. Today we have one candidate. So Ben is going to be
treated gently because it's been a while.
Yeah, okay. All right, let's real quick summary for the Vivas. So it's all going to be highly clinically orientated. So there's going to be a STEM, except for often the first question, which is sort of rapid fire to warm people up.
Yep.
So there'll be, 6 or 7 single slides, which will be the rapid fire ones, and then they'll go into clinical STEM questions. I'll start off with a STEM, and then you'll see the echoes, and the echo is going to be relevant to the question, right?
Remember it from last time.
Yes. The idea is to go for the money. You're not doing a medical school exam. You're talking about, if the LV is down, start with that. If the RV is huge, start with that. Go for the money. Talk clearly, confidently, no ers, no ums. It's all about giving that impression of competence. Okay, not the impression, displaying competence. Good, being competent. Okay, there's nothing going to trick you. There'll be 7 or 8 questions. 90% of them will be TT or TO. Normally, we've got one general ultrasound question in it. Mm-hmm. Okay, case 1. 65, normally it's 1 minute per slide is the general key.
Yeah.
Okay. So 65-year-old female, shortness of breath. Do you want to be in charge of the screen? Because often, as the candidate, you're going to be in charge of the screen. So I'll let you do the arrow. Yeah.
Right. 65 woman, breathless. All right. So in this apical 4-chamber view where I'm looking at the left ventricle, the thing that concerns me the most is what I can't see at the apex left ventricle. Whilst there may be some dropout there from some near field clutter, I'm worried already that there's a mass sitting within the apex left ventricle in this view. Overall, the left ventricular systolic function is relatively preserved, I would say, but I need to see more views to be sure. Apart from that, I can't see much else in this study, on this image.
What walls would you be looking at?
I'm looking at the anterolateral and the infraseptal.
Nice.
To the screen, right screen left.
Okay, what would you differential? Think there's a mass at the top. What's your differential?
Yeah, so my differentials are thrombus in the first instance, assuming it's a real mass. Artifact would have to exclude, but thrombus, malignancy, so that could be primary or metastatic. With my 2 main differentials in this case. So I'll just do that.
Okay, next one.
Yeah. Okay, apical 4-chamber once more with color Doppler to assess whether there's flow within the or over the lesion or over the left apex. There does appear to be blood flow over the area of concern in the near field of left ventricle, making me less worried, but does not exclude a mass in this left ventricle. It may also be foreshortened. I can't see completely the left atrium inferiorly or at the inferior edge of the sector, which could give that impression of there being a thickened or mass in the apex of the LV.
So, yeah, okay, what further into
that? So I'd like to do a full transthoracic study and then proceed to a toe to better identify what's sitting in the apex of the left ventricle. A contrast study as well could be performed if I had access to contrast.
What's your money
on? Toe.
Oh, no, sorry. What's your money on for differential?
Look, I still am worried that there's a mass in the LV, in the apex of the LV, history of stroke, but the LV function is reasonable, which makes it less likely that's occurred.
Yeah, no bad.
Differential.
Okay.
Yeah,
because this is, I think with this bleeding artifact, this has got to be artifact.
Artifact, yeah, okay.
So, the bleeding of the color Doppler through there.
Yeah.
I think all the things are reasonable. The big thing again leans me also towards the being an artifact is that I think we've got reasonable thickening of the apical segments. If you've got akinesis of the apex, that is an enormous mass. It's going to be a thrombus. So yeah. So again, I think we've got movement up there. I don't think that LV function is normal, but it's not horrific. But I do think that is down somehow.
Yeah.
But it looks global. It's not
segmental.
It's not segmental. And if you got that apical clot, it's in there. So artifact. So history of CVA, cool. Right, case 2.
Yeah.
Sorry, just before moving on to that, there's an interesting finding on that study. And I thought initially it was the coronary sinus because they're tipped too far posteriorly. But you see that tube, can you see my pointer? Probably
No.
not.
No.
Just below like the mitral valve, you
Yeah,
see that
nice.
tubular structure.
Yeah.
And I'm not sure that's coronary site. I think that could be anomalous coronary artery.
No, I think that's artifact.
Here.
Is it?
Look at it
No,
come in
no.
and out with the.
No, not that one, Sam, the one next to it.
Oh, nice.
Over here.
No, I think she's talking about.
No, that
It's
that
pretty
thing
hard with some dodgy imaging, though, isn't it?
I know, but it's suspicious for that, isn't it? It's there on that one as well.
So I think the one underneath the lateral annulus looks to me to be artifact. I think that's a side lobe artifact because of this calcification that you've got right in there. This one in there. You're not talking about that, are you?
Yeah, I am talking about that, but it's more prominent on the. I thought it was just a bit of coronary sinus we were getting.
Oh,
Yeah,
okay. Yeah. I see what you mean now.
Because I think that's side lobe artifact from over here.
Okay, it might. I
Look
mean,
how it moves with the.
With the rest of
It moves with that highly echogenic structure. So I think there are just loads of artifacts that are in here. Okay, so how are you going to differentiate? Okay, so we've got two areas of artifacts, and even Emma and I are going to slightly disagree on that. How are you going to determine whether something's an artifact or not? What kind of imaging you want to do?
So I want
contrast, toe.
Yeah, so I look at it in multiple planes, including off-axis imaging to see.
Yeah, nice.
I want to make sure I've optimized all my settings in terms of depth and focus to exclude any other potential things that may be coming to play. And then once I've done those things, color Doppler, contrast, and toe if I can't exclude it any other way.
Beautiful. Yeah. So changing the depth, changing the focus position, changing the angle of interrogation, different views, and transesophageal echo. How would you know, what does color Doppler do to show an artifact? Well, you said you wanted to use color Doppler to differentiate.
So if the structure is true, then there should be no color flow over that structure. Whereas if a structure is an artifact, then you should have blood flow represented by color Doppler over that structure.
Okay, case 2.
80 ml septic. Polymyalgia, right? Sorry.
Yeah. It's pretty dodgy imaging. I did this when I was learning echo, but I love this case. I did it as part of my DDU case study.
Yeah, right. Okay.
But anyway, I like sticking there.
Okay. Sorry, I missed you. I was making attention. Was he on anything? No, just hypoxic, but he's not on any. No, right. So in this apical 4-chamber view, he's got multiple features that are concerning to me. There's a left ventricular systolic function that appears to be impaired, and there's some mitral regurgitation that in this single view may well be at least moderate in terms of severity. With respect to his right heart, the basal dimension appears dilated. I can't say much more about that. I'd like to go from there.
Okay. So talk to me about this mitral regurg.
Yeah, sure. So
we need more depth for this because this guy's sick as a dog, right?
Yep.
So he's septic shock.
Yep.
Okay, and we're never going to show anything gentle. He's hypoxic and he's immunosuppressed, right? So what before we go any further, what are you going to think as you launch into this? If someone's hypoxic with septic shock, what do you think I'm going to be showing you?
So you could be showing me a heart that's down because of septic cardiomyopathy, style picture. You could be showing me just a bad heart from other disease. You know, he's old. You could be showing me infective endocarditis where he's blown out a valve and he's now got disease that way. That'd be my main. First
and if he's immunosuppressed,
then it could be
the past medical history is always going to be important. If he's immunosuppressed, what are you going to think I'm going to be leaning to?
Well, then probably
Yeah, fantastic. So it's going to be, it's absolutely, that stem of the question straight away, as you said, you're going to think I'm looking at infective endocarditis. Okay, so talk to me about that. Look at that mitral valve for me a little bit further.
Yeah, sure.
So you called it moderate.
So
just have another think about that. What are we looking at there?
So in this view, I can see a broad jet of mitral regurgitation where there's looping around eccentric around the wall of the left atrium, exhibiting coanda effect. I can't see how far down or if it goes into the pulmonary veins. There is an area of
how far do you think it goes?
Oh, I think it does go down to the back of the left atrium.
Yeah,
and I think if I could interrogate the pulmonary veins, I'd expect to see flow reversal, systolic flow reversal in the pulmonary veins.
If you call it moderate.
At least moderate, yeah. So
At least moderate. That's okay, but okay, keep going. What about the rest of it?
So yeah, so there's an area of flow convergence, and it appears to be broad based. I need to slow it down to be sure. I'm suspicious there may be multiple jets of MR, one that's more to the lateral edge of the screen or to the right side of the sector, lateral edge of the sector. I can't quite work out whether I'm seeing at this speed, I'm seeing another MR jet that's sitting in through here.
Yeah, nice.
There may or may not be.
Absolutely. So I think you're looking at multiple jets. I think this idea of this jet coming over point and going anteriorly from the mitral valve is absolutely in there, because it doesn't look just like a single one that's curving around. It looks like there's almost this splay effect
coming through. Yeah.
And I think then with the Coanda effect, what's the Coanda effect going to do to a color Doppler estimation of severity? So,
I mean, the Coanda effect shows me that what I'm seeing is it's going to be more severe than what I'm seeing. Fantastic. So we'll underestimate.
Excellent. So, and if we see it going all the way to the back, I think we'd be able to, with a reasonable level of confidence, point towards this being severe.
Yeah, right.
Okay. Now let's have a look at the left ventricle. So what do you think about the left ventricle? So the left ventricle is down. Yeah. Again, if we're going to say anything, we're going to try and be specific with our terminology, and you're going to say that's mildly, moderately, or severely impaired. There's no mild to moderate or moderate to severe. So to have another, what do you think about that? What do you think the left ventricle function? What would be the ejection fraction if you had to guesstimate it?
Okay. So the systolic function of left ventricle is actually probably normal. Now I look at it. I think that the
I agree.
The anterolateral, if anything, is going to be hyperdynamic. I think it's hyperdynamic. The anterolateral wall looks to be coming in pretty well, and the infraseptal wall, whilst the basal segment isn't moving very much, that doesn't necessarily mean that his LV is that particularly down. So I think if anything, it's probably a normal or hyperdynamic LV. It's not impaired.
Okay, next. So acute versus chronic.
So I'd be more leaning to this being acute, because the left atrium is not significantly dilated, and his LV is not significantly dilated either, suggesting chronic volume of it.
Very nice, excellent. Right, so that's the kind of stuff that would be good to get out without the examiner having to prompt you. I think we should be able to pick up straight away that we've got a hyperdynamic left ventricle, which is normal in size. You've got maybe a mildly dilated left atrium, but it looks like you've got severe MR.
Which is
We've got the aliasing, the variance that's on. We can see multiple areas of green in there, which suggests, I mean, I think I probably got my scale a bit wrong. 63 says not perfect, but it's not too bad. So you've got multiple areas of chaotic blood flow, potentially multiple jets. We've got this eccentric Coanda effect with the color Doppler going to the back. I think all of this points towards it being acute, with that background of being septic shock with catecholamines, with being immunosuppressed. All of this, you show from that one thing, we've got to start saying, I'm highly suspicious for infective endocarditis based on this. Because it looks acute, it looks severe. If you've got acute, severe, someone septic shock, immunosuppressed, I want to know whether beautiful.
So I've come around to the subcostal views. Similar to the apical views, this shows this appears to show multi-jet MR that is encompassing the near majority of the left atrium, consistent with severe mitral regurgitation. With this color, this broad color flow, I can't clearly see whether there's valve prolapse. I need to take off the color to do that, or a clear vegetation. Again, the left ventricular systolic function is hyperdynamic, and right ventricular systolic function is likely hyperdynamic, but I can't see the free wall very well due to some near field clutter.
Nice.
There's within the right atrium, although I can't see it well, there may well be tricuspid valve lesion or prolapse, or that may be
show the tricuspid valve.
Let me see up here.
So
I can't see anything flicking back. So this could be just a Chiari network.
Nice. Or
stenosis vasa? No. I could tell. I shouldn't have sworn it's being recorded. No, I've forgotten.
Eustachian
ridge. That's it.
Eustachian ridge. Okay. So I think it's probably the Chiari complex is probably,
Yeah.
I mean, maybe it's a little bit more web-like. and
Yeah.
flowing around, but that looks like the eustachian
Eustachian.
ridge because it's just this one
Yeah.
line that's
It's
coming up
flicking.
here.
Yeah, it's flicking,
Alright,
coming around there.
Yeah, good.
Yeah.
All right. So again, I think that in terms of the confidence and the delivery of this, if you're seeing this twice, this is absolutely rip-roaring MR in there.
Yep.
So saying things like, I'm extremely worried by this picture, or
Mhm.
this is extremely concerning for significant destruction of the mitral valve.
Yep.
This is massive, broad-based, multiple jets, huge color Doppler, massive chaotic motion. Get that sense of urgency coming with this, because I'm also not going to show you gentle pictures. They're going to be fairly obvious.
Yeah.
And I'll be asking questions like, what do you want to see next? And with everything of this, it's multiple views, off-axis imaging, as you said, and you can start to see the huge lesion when we start to go off-axis. It's incredible. We missed it just with the standard views, right?
Yeah.
All right, let's do some toe images. Okay, so can you label the anatomy for me? And the mitral valve scallops.
Probably not the scallops. So left atrium, left ventricle.
Yeah.
This is going to be the anterior wall and the inferior wall.
Excellent.
And then this is going to be A1, A2, P3.
Maybe. Yep, absolutely. So I think it could be P1, A2, P3.
Yeah.
I'll take A1. Nice one. You got them the right way around. That's excellent. And obviously massive bloody
And a large lesion on the
critically analyze this image for me. Again, I was just learning toe, so give me a break.
Sure. It's only one cardiac cycle at most, and the physio trace is, I'm struggling to see where the P and QRS are. So I'd like it to be a touch longer in terms of time. The color box encompasses the left atrium and left ventricle, which slows down the frame rate. If we're looking to assess either one side or the other, we should focus the box on that. Assuming we want to look at the mitral valve, our focal position is all right, but I'd make the sector less wide to, again, further increase the temporal resolution. So it's an okay image.
And keep going with the Doppler. What else with the Doppler?
Yeah, so in terms of color Doppler, so if I'm looking to more thoroughly assess the regurgitation or the regurgitation, I'd change the scale of the Doppler
What do you want?
to make the numbers higher.
Yeah. So what numbers do you like that?
Up in the 60s, and I'd get rid of the variance because the green is distracting.
Yeah, let's move on through this. Okay, so what are your conclusions, and what would you make? What would make you refer to cardiothoracics?
So this patient's got septic shock with infective endocarditis on the left side with valve destruction and severe mitral regurgitation. And this is a surgical emergency. What would make me refer to the surgeons is this patient. So they're critically unwell. They have a very large lesion on their mitral valve. And whilst they're holding out the hemodynamics for the moment, I would not expect that to last. So we need to address this surgically because this won't be fixed medically and sooner rather than later.
Nice.
If we'll need any additional cardiac support.
Yeah, nice. Just go. Don't forget about the Duke's criteria. I haven't shown any blood cultures there.
Yeah.
We haven't talked about the heart failure signs and symptoms. He's in septic shock.
Yeah.
But I'd be talking about heart failure in there and the size of the lesion, remember. So they classically talk about greater than a centimeter. Just make sure we're going through those Duke's criteria.
Yeah.
I'm gonna jump in if I'm missing anything, okay? Lung ultrasounds. Shall we skip those because you're a respiratory physician? Okay.
There's nothing there, is there? 34 years old. First pregnancy, ED, shortness of breath, last 5 days, acute worsening. Tachy, hypoxic, hypotensive. Okay. AP chest film, the left ventricle looks enlarged on this view. Can't comment really on the cardiothoracic ratio because it's an AP film. The lung fields are otherwise clear. There's no fluid in the
So what are you about to see?
So I'm expecting to see a woman that's got, or a transthoracic echo that's got peripartum cardiomyopathy.
Yeah, if she's short of breath, though, acutely short of breath.
Yep. I'll be thinking peripartum cardiomyopathy. It's been progressive over 4 or 5 days. She could have a pulmonary embolus where I'm going to see a blown out right side of the heart.
Nice.
She's got a splayed carina, so I'm being a bit worried that the left atrium will be dilated, hence the LV problem and the heart water.
Again, won't be subtle if I'm giving you LV failure or someone with mitral stenosis or something in a splayed thing, she's going to have loads of pulmonary edema.
Yeah, right.
So if you've got clear lung
I've got
fills,
still looking at chest X-rays. So okay, so parasternal long axis with normal to hyperdynamic left ventricular systolic function. Don't have a heart rate there, do I? It's not hidden somewhere. That's right.
Yeah, high.
Yeah, tachycardic. That's right. I was on the other slide. Tachycardic. So the right ventricular outflow tract appears dilated. It's larger than the aorta and left atrium. The left ventricle is hyperdynamic and potentially underfilled. The left atrium certainly appears small, given her tachycardia and what looks to be maybe a large mitral annulus and then Orde. I'd be potentially worried about her developing some outflow tract obstruction. Her lung fields in the far field of the sector show multiple B lines concerning for pulmonary edema.
Cool.
We'll come around to the parasternal short axis at probably at the level of the mitral valve. I can see it flicking. Concerningly, there's a significantly dilated right ventricle. There's flattening of the interventricular septum in systole and diastole. I'd like to slow it down to be sure, but I believe it's going to be both. Making me demonstrating pressure and volume overload of the RV. I'm significantly worried now this woman's got a PE, potentially life-threatening PE. I'm going to, what's that, 3.5 roughly. So apical 4-chamber. Her RV is significantly impaired from a systolic function perspective. It's dilated, it's apex forming, and at the moment she's still generating enough pressure to have a relatively to have a high tricuspid regurgitation velocity. This woman's got pulmonary embolus until proven otherwise. It's life-threatening in her. Not surprisingly, her TAPSE is relatively preserved. She's got good longitudinal function, but she's got she had akinesis of the midventricular free wall, which is McConnell's sign. So whilst the TAPSE is normal, it doesn't mean that her RV systolic function is normal. Embolus.
Cool. Following tangent.
So McConnell's sign is hyperkinesia, akinesia of the midventricular free wall on the right with a normal to hyperkinetic apex. Classically seen in PE, but it's also seen in RV infarcts. And 60-60 sign is when your RVSP is greater than 60 and your pulmonary acceleration time is less than 60. Both classically seen in PE.
Nice. So your systolic.
Normally your RVSP will be less than 60,
than 60.
and your acceleration will be greater.
Less than 60, so they're both less than 60. So often you've got completely blown out RV, acutely it's happened. You can't generate super high pressures.
Yeah.
So you're not going to get super high. You're going to massively increase pulmonary vascular resistance, and your RV can't cope.
So their acceleration time is under 60.
Yes, exactly.
And their RVSP is greater than 60.
I have it under 60.
No, it's less than 60 because if you're seeing it as Sam was saying higher than 60, it's going to have an element of a chronicity to it. I'm actually surprised that she was able to generate that much pressure.
What, 3.5 hers was what?
How much was it? I couldn't see actually.
Like 55, and then add on the right atrial. It's actually pretty cool.
So she has not 60 sign.
But how far on in her pregnancy was she?
I can't see it. Can you see it in there? What is this?
She's 35 weeks into her pregnancy.
Yeah, I wonder if her high volume status and high cardiac output is enabling her to generate that higher pressure.
Confounder.
Usually they'd be dead hay if that was acute, and they
3.5. So what's that?
Yeah.
So I can't need to see the number. What's the number up there? As I say,
it's 3.7. It gives you 55, and then add on right atrial pressure.
Okay, so she's seeing she's a bit turbo.
Yeah, but the 60-60 sign is PASP less than 60 and accel time less than 60.
Less than 60.
Yeah.
Because the RV can't
cope. Yeah, can you back the stem? 75-year-old female, hypotensive, collapse at home, deterioration in the last months, hypotensive in ED on. Okay, so this is a very concerning parasternal long axis. Most strikingly, there's biventricular dysfunction. The left ventricle appears dilated with severely impaired systolic function from what I can see. The right ventricular outflow tract appears dilated and likely is going to have poor function from what I can see. The left atrium would be enlarged, and the aortic valve there was no history of aortic valve surgery, then that looks like a significantly calcified aortic valve with reduced mobility of the leaflets. That doesn't mean she's got aortic stenosis, but that would be differential for this case. So I'm quite worried about this woman, in the fact that she's been started on inotropes is even more concerning, and this is what her heart's doing. She's also got significant B lines in the far fields.
Yeah. Don't worry about that. Actually,
dimensions. So I'm guessing you're looking at, so top left, you're looking at left ventricular dimensions, and the end diastolic dimension, I'm guessing that's going to be 8.
The internal diameter is 57.
And the end systole is 57 as dilated. And then we're looking at through our mitral valve, so our E-point septal separation, which will be greater than 6, which is representative of either poor LV systolic function or reduced excursion of the mitral valve. So if you've got a dilated couple.
Very nice.
Okay.
Maybe on.
Okay, continuous wave through the aortic valve from the apical 4. Our Doppler alignment looks pretty good. So our maximum gradient is 3.46. So we're assessing for aortic stenosis. This puts into moderate, likely at least moderate aortic stenosis off the maximum velocity of 3.46. Our mean gradient is under 40. However, given that she's got a significantly impaired LV systolic function, these numbers are likely underrepresentative of what the degree of stenosis truly is. In other words, she's got low flow, low gradient aortic stenosis.
So what do you want to see?
So I'd like to see her dimensionless velocity index.
I don't know how to get rid of this. I don't want to.
That's right. So that is, yeah. So 14/77 is going to be under 25, under 0.25, suggesting severe aortic stenosis.
Oh, this is correct.
Okay. Right, urosepsis, no time.
Sorry, Ben. I think it's an important point on that last one though, Sam, just to mention. What else would you want, Ben? Not just the DVI, what else would you be calculating to know whether there's discordance? There's a couple of other key parameters. You mentioned low flow, low gradient. How do you define low flow?
Nice.
This is something of a body surface area, and there's a 0.35 or a 35. I can't remember. Is that this thing? I've got
Yeah. So low flow is when the stroke volume index is less than 35 mils per meter second.
Yeah.
And then how would you work out what else would you want as well as the DSI, the DVI? You've got the numbers to work it out there. Now, how would you do it?
Oh, yeah, fair enough. Yeah.
So you get your volume. Do you know what I mean?
No. So you've got the velocity, you've got the mean gradient, you've got the DSI. What are the other parameters in the box for severe aortic stenosis?
Gradient, velocity, and then aortic valve area.
Nice.
Yeah, nice.
So
how would you calculate it with those numbers, and what would be severe?
So it's A1V1 equals A2V2. So you need your area and your volumes, and we've got our LVOT diameter. So that's fine. I have to write down. It's area. It's like A1V1 equals A2V2, right?
Yes.
And we have our V2. We have our LVOT diameter. So that will be our A2. To get our volume, its diameter, it's pi r squared. So half that to get the radius, times that by pi, times by the VTI. And then that gives you your volume. And then we've got our VTI for the aortic valve flow. And we have to write it down. That's right, man.
Yes, exactly right.
Yeah. But that's the formula.
And so what are the you talked about volumes, the area times by the volumes. It's not quite
volume, is it?
So you've got area times. So what are the units for VTI? What's VTI measuring?
It's centimeters squared.
No,
No,
it's on there. VTI, the AVI, VTI.
centimeters.
So you've got area times by distance.
Area distance.
So area
that's
times by
So it's the
distance
column
give
of
you
blood.
volume.
It's how much the
So
blood
then the
moves.
volume there is
Yeah.
the same as the volume there.
Yeah.
There's still one squeeze of
blood. Yeah.
So as long as you're measuring the volume and the area in the same place,
Yeah,
you're okay
then
for the
you're right.
LVOT VTI.
Yeah.
Okay, so yeah, you've got the LVOT VTI, you do pi r squared or
Yeah.
0.785
times the
squared,
diameter.
whatever.
Yeah.
And you times that by the distance it travels, which is the VTI.
Yeah,
So that's where you times by 14. In the same units, you can then work your way backwards.
Yeah. Yeah.
So 2 questions. First of all, what's severe
For
aortic valve stenosis?
so less than 1 or less than 0.7. It depends if you're going by body surface area.
Yeah, nice. What are the potential pitfalls in that calculation you've just made?
So there's a few. So we have to be accurate with where we're measuring. And if we've got flow acceleration leading into the LVOT or aortic valve, then we can place our gate in the wrong area. The other concern is if there is, or going with that is if there's increased flow velocities leading into the LVOT and the aortic valve, then you can get your initial velocity be greater than 1, so you can't use the simplified Bernoulli equation. Is that right? No.
Yeah, it's. I think going through this will be really, really
Yeah,
important. That would be pass fail for me in there because you're absolutely right on all of that. But you've got to. I want you answering that question in about 90 seconds.
Yeah.
And I'd suggest go through it however the structure, however you want it. I would go through it as the continuity equation we just talked about. So the difficulties, if I was going to try and answer that question, and this is the kind of cadence I think you should go, the difficulties are potential sources of error. Fundamentally, the first one is the LVOT diameter. It is hard to measure it in that patient. You've got to be measuring in exactly the right spot. And any error that you make is going to be squared, and that will have significant implications on your calculation. Next one would be the LVOT VTI. You've got to measure it in the same place that you measured the LVOT diameter. So that means I need to see my close and click. I need to make sure my angle of interrogation is absolutely perfect. My gain and everything settings are completely correct, so that I'm then measuring my VTI correctly. Same principle is also going to be the same for the aortic valve via the continuous wave Doppler. Again, angle of interrogation and making sure that my gains and everything are set correct, and I'm tracing just the modal velocity. Okay, providing all those are correct, I'm also going to do multiple angles of interrogation. I'll choose the maximum value for each of those. Okay. Then you can start talking about risk of flow acceleration and things if you want to chuck it into there. But just trying to figure it out quickly and smartly in less than a minute, ideally, is what you need to try and do. The same thing will be if I show you a mitral regurg case. I'll show you a couple of pictures. What further images do you need to analyze it? Again, I want to have a look at it with 2D, looking for significant obvious valve abnormalities that are going to suggest severity. I'm looking color wave Doppler, been watching for eccentric jets with a commander effect, underestimating things. I'm going to use my pulse wave Doppler, I'm going to use my continuous wave Doppler. I'm going to make sure I check downstream of it. So just having a nice little package for each of the valves, because we are not going to have the ability to show you an entire sequence. We are also not, we don't do enough valve analysis. So just have nice little practice, nice little nuggets for all of that.
Ben, we talked through that last week, which are going to be uploaded to the website. So maybe check out the 2 first cases from last week. There's some good aortic stenosis, so one's on there as well.
Cool.
Good consolidated.
Right, where's normal toe? Redo March. Right. So in this parasternal long axis, what I can see is, in this parasternal long axis, there's multiple findings that may be contributing to this shortness of breath, let's do orthopnea. There's preserved left ventricular systolic function from what I can see in this single view. The aortic valve that's been replaced appears to be rocking in the inferior aspect of the valve. And I can't see good motion of any cuffs that are in there. I'm not sure whether it's I'm assuming it's, I can't remember if it's bovine or not. The original was bovine. Don't know what this was.
You gonna tell me?
It's a tissue valve.
Yeah.
With struts. So I'm concerned that is dehisced from the way it's appears to be rocking. The left ventricle isn't dilated as yet, but I'm going to be worried that I'm going to see significant regurgitation across that valve. I'm seeing significant regurgitation across that valve. So color box over the aortic valve, which is pleasingly moving. At high velocities, there's a lot of turbulence, high variance, and I'm worried that there's going to be significant regurgitation. Well, there is significant regurgitation across this, and likely impaired outflow as well.
Impaired outflow, so what do you mean?
So impaired ejection. I just think there's
chaotic motion both sides, you mean?
Yeah.
Yeah, stick with the regurg, I think.
Yeah.
There's chaotic motion on both sides, yeah.
Yeah. Oxygen as well. So in this apical 4-chamber view, there's impaired systolic function of left ventricle, and with hypokinesis of the apex, and there's the appearance of a structure likely within the left ventricular outflow tract or aorta that's cutting through and is giving artifact across the mitral valve. What is that?
You tell me.
Oh, I don't know. The mitral valve itself, excursion appears limited during systole. That structure doesn't appear to be attached to the mitral valve in this plane, but it could be out of plane. It's on both the ventricular and the atrial side. And this may be a prolapse of a mitral valve cusp, but I wouldn't expect it to be so large without there being significant.
I forget what you're saying before, right? Tying yourself up in knots.
Yeah, so what I think I'm seeing is
an artificial valve. You've got an artificial valve in there, which buggers up all the sound waves, and it's rocking.
Yeah, so I think I'm seeing that come through.
Very nice, very nice. So then you've told me already we got severe regurgitation. And then if we're seeing that, you've seen the left atrium already in another view.
Yeah.
So prolapse of the mitral valve?
No.
This is just your
dehisced valve. Yeah, just coming through in an out of plane. Right, so in this color Doppler over the mitral valve and catching some of the LVOT, there's mitral regurgitation that is going to say at least moderate. I can't see the base of the left atrium to see whether it's truly wrapping around. It appears multi-jet and it's broad-based. And it's most pronounced over the anterolateral aspect of the left ventricle going to left atrium. There's significant amount of turbulence feeding into the or in the area of the LVOT. This represents aortic regurgitation and turbulent flow. So the aortic regurgitation is going to be severe, and the mitral regurgitation is at least moderate. I'm not going to call it severe because I can't see the true base of the left atrium, can't see the pulmonary veins. I need to assess it in other views to be sure, including extending down.
Between acute versus chronic aortic regurgitation.
So compensatory mechanisms of the LV. So if the left ventricle is dilated with preserved function, that suggests it's going to be chronic because it's been time to adapt. If a patient's gone into acute pulmonary edema and their left atrium is not significantly dilated and there's significant MR, that'd be more about being acute. So what the LV has done in terms of compensation.
Yeah, okay. Diastolic MR would be another one for the acute, and I think she does. You've got to pause and slow it down, but I think you've got sort of like a persistent blood flow that's there. I mean, it looks like we've got an unusual rhythm, but I think there's diastolic MR in there as well.
Yeah, right.
Don't worry about that. Discuss conclusions. Right, let's finish up this one.
55 point.
What a terrible reason for not doing the angiogram. I'm good.
Dissection.
Excellent.
In this mid-esophageal 5-chamber view, and there's, I'm going to be slow here because I haven't looked at toes in a while.
Yeah.
Yeah, it's on
It's
my,
going to be toes.
yeah, I know. It's on my
Yeah.
list of things to do. I'm going to get some time with Bob. All right. So there's, where's that? There's a structure within the left atrium that is flicking in and out of plane that may represent thrombus. The systolic function of the left ventricle is normal to hyperdynamic. Mitral valve is opening well. The excursion of the mitral valve cusps are fine. There's a echodense heterogeneous structure that is flicking in and out of the left ventricle as the mitral valve opens. Whilst it's out of plane and maybe artifact, I'll be concerned about there being thrombus or something else that could be attached to that.
This is just a Siemens machine that gives you a lot of sec, actually.
Yeah, right. That's what I
So
thought. That doesn't make
normal
sense.
versus hyperdynamic, just say one or the other. I think you'd be fine with either. I think that's hyperdynamic.
So that's just the Siemens machine, is it?
It's just the Siemens
Right, okay.
machine. Let's
Here we go.
for that one.
There. All right, so we'll come around to the 3-chamber at the mid-esophageal. There's a centrally directed jet of aortic regurgitation, which appears to be associated with prolapse of the aortic valve. I'd like to set the color off to try and better identify what cuffs it may be. At the edge of the sector, there's the appearance of the aorta that's becoming wider, and I'm worried that there's going to be a dissection flap sitting within here, especially in light of the aortic regurgitation.
Okay, let's go next one.
So, zoomed in view of the same area. So, I'm very concerned here that this aortic valve is no longer competent. There's likely prolapse of one of the leaflets or a dissection flap evident in the non-color screen. In the color sector, there's likely multi-jet aortic regurgitation that's broad. I can't, and that's all I can say.
How severe do you think the aortic regurg is?
So it's going to be at least moderate, if not severe. The vena contractor is going to be 5 or 6, if not 7 millimeters in this view. Whilst the regurgitant jet is small, that can be a factor of angle and left ventricular systolic function. But based off the width of the vena contractor, I'd say it's going to be at least moderate.
I mean, I'm going to call severe with this. Again, I think you're being conservative with some of this stuff. You've got someone who's normal beforehand, right? We've elective angio for non-STEMI with, you know, she's okay and she's gone home. And then suddenly she has this difficult procedure. Something's happened, small RCA dissection requiring stent. And then you've already told me, you know, that is massively worrying for me. Because it's eccentric. It's broad-based, as you said. I think we're seeing the dissection flap. You've told me everything. And then you're going to say moderate AR for this, man? Not a hope, man. We're just not, we're just seeing everything off axis. It's going to be eccentric as hell. And this lady's got a dissection coming up. I think she's got this hyperdynamic LV, which is exactly as you'd expect to see. I mean, maybe I give you this stuff, but, you know, we were seeing this right down in here is where this dissection flap is going right the way down to the annulus. That's clearly where we're getting the aortic regurg from. It's going to be severe. So talk to me about dissection flaps. Can you tell me how do you grade your dissection or grade it? How do you classify your
so there's type A and type B, depending on where they originate from. So whether it is from the aortic root or whether it's from the distal side of the vessels extending into the neck. So it's Stanford. I remember the classification. Orde, there's the 2 of them. So whether it includes the vessels that go up into the neck and arm. So it's a classification.
And tell me about how you're going to differentiate between the true lumen and the false lumen. So hang on, maybe you'll say, which one is this? So you got type A or type B?
Type A.
Nice. So we're going down into 40 centimeters there and descending aorta. How do you differentiate between the true and the false lumen?
Yeah, so the true lumen will be have greater blood flow. In systole, it will be typically bigger. And as you extend down the aorta, the true lumen can get smaller from memory. I've forgotten. I've got a table of this.
Yeah, go through that.
Yeah,
I think
definitely.
you can use things like M mode to have a look at the flutter. It's the movement during systole. It doesn't always have to be bigger, the true lumen. It depends that the false lumen can be bigger. It depends where all the blood's flowing into it. But you're using M mode to help try and differentiate the movement during systole.
And isn't there color as well?
Yeah, absolutely. Yeah. So color flow, more like to get the color flow during the true lumen, right? As opposed to the false. So you can use your pulse wave Doppler in there. And they're all depending on the size of it and where the hole is.
Yeah.
And trying to find the entrance site is
entry point. Yeah.
Cool. Yeah, look through some of those.
Yeah, definitely.
What would you do? Cool. Yeah.
Surgeons.
Yeah. So do you know any, I don't think this would be in the exam, but they classically say that I think if it's within 4 or 5 centimeters of the ostium,
whether you speak
then you
to
conservatively manage it. Conservatively manage it. If it's greater than 4 or 5 centimeters, I can't remember, 4 or 5, then classically they go and have to try and do the replacement of the whole aortic valve.
Yeah, right.
And do the whole pentals.
Yeah, that's the whole thing.
That's it. That's an hour. Good job. Good job. All right. Okay, thanks very much indeed for doing that. Sorry, you got absolutely smashed with all of that.
No, it's all I want.
It was useful. Thanks for joining, Emma. Really appreciate it.
Thanks, Sam.
Thanks, guys.
See ya.
Bye.
Bye.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.